My name is Loren Rabinowitz. I'm an instructor in medicine at Beth Israel Deaconess Medical Center in Boston, Massachusetts, and I'm going to be talking about some updates in pregnancy and IBD geared towards this year, 2024. A couple of learning objectives. We're going to talk about pregnancy and IBD. We'll review a little bit of the epidemiology and why this particular population is so vulnerable. We're going to talk about an approach to preconception from a patient perspective and from a provider perspective as well. So patient counseling and medical and surgical optimization. We're also going to talk about managing IBD patients during pregnancy in terms of preventing flares, managing flares if they happen. And I want to spend some time talking about the postpartum period with some special considerations for the mother and also for the infant. So, why talk about inflammatory bowel disease in pregnancy? Well, there are approximately 2.4 million people living with IBD in the United States. That's divided equally between UC and Crohn's, and approximately 55% of those patients are female. And while the onset of disease can occur at any age, peak incidence is in late adolescence and early adulthood. So what that means is that many patients are relatively newly diagnosed at the same time they may be navigating difficult family planning considerations and decisions. Unfortunately, we still have less data on treatment efficacy and safety in pregnant and breastfeeding women because this is a vulnerable population, although that's changing quickly. And perhaps some of us were not as exposed to the care of pregnant patients during gastroenterology training and beyond. So I want to start by talking a little bit about preconception. This is a really crucial period for patient education and a critical period for the optimization of therapy. Voluntary childlessness may impact both male and female patients. And voluntary childlessness means the choice not to have biologic children, which is largely driven in IBD patients because of lack of access to education. The most common sources of information for many of our patients are us, gastroenterologists. So what that means is that there is this critical window where we have an opportunity to teach our patients about the impact that their disease may have on their decision to become a parent. Inheritance in IBD is particularly concerning to many patients. They worry that if they suffer from Crohn's or ulcerative colitis, that they may then have a child who suffers from IBD as well. And in this area, we can be relatively reassuring. And while there is an increased risk of developing inflammatory bowel disease, if you have a parent with inflammatory bowel disease, the risk is actually highest with a sibling, likely because of both genetic contribution and also the environmental exposure aspect as well. There's an approximately 1 to 4% chance of developing IBD in a child of a parent with inflammatory bowel disease. Another aspect that may be particularly worrying to patients is the risk of infertility. And in this area, we can be particularly reassuring that the biologics do not increase the risk of infertility. There may be impact on fertility in patients who have undergone a colectomy with IPAA, although a lot of the data comes from the pre-laparoscopic era, quoting 15 to 48% increase in infertility in patients who have undergone colectomy with pouch formation. Newer data is a little bit more reassuring and suggests that fertility impact following IPAA, if done laparoscopically, remains, but is probably less pronounced. We think this may be due to decreased adhesions or scarring following laparoscopic as opposed to open surgeries. Then we want to think about how we optimize patients and their disease. And what I mean by optimizing is, really honing in on how well they're doing and getting them into deep remission, approximately 3 to 6 months, ideally prior to conception. And the reason that this is so critical is because we know that inflammation can lead to poor outcomes for infants. This includes the risk of low birth weight, small for gestational age babies, preterm delivery, and other considerations as well for the mother, which I'll get into a little bit later in my talk. We often will hear this sort of quoted natural history of diseases, the rule of thirds. So a third of women will stay the same during pregnancy, a third of them will flare, a third may actually improve. But what we really understand is that women who conceive in remission typically remain in remission. There are some really critical things that you can do during this preconception period, in addition to educating your patients. One is to encourage female patients who are planning pregnancy that they should start taking a prenatal vitamin that contains at least 400 micrograms of folic acid every day. They should start vitamin D supplementation if it's indicated, and they should strongly consider the use of a baby aspirin in order to mitigate the risk for preeclampsia. There's a nice study that came out this year that actually showed that the use of baby aspirin during pregnancy in patients with IBD does not increase the risk of IBD flares during pregnancy and may be helpful, again, in decreasing that risk of preeclampsia. You really want to make sure that these patients are vaccinated and that all of their vaccinations are up to date. This is especially important if the patient is immunocompromised. Ideally, we also want to use this opportunity to restage disease prior to conception. And what I mean by that is you want to do a full biochemical, radiologic, and endoscopic evaluation to really confirm that the disease is well controlled. You also want to use this opportunity to think about what treatment strategies really make sense, not only in the preconception period, but will also offer excellent safety and efficacy during pregnancy and also postpartum when patients may choose to breastfeed. This is an area that creates a lot of stress and anxiety for many patients. Are these medicines safe? Will they harm the baby? And so I'd like to get into a little bit of detail in some of the more commonly used medications in inflammatory bowel disease. We'll start off with the 5 ASAs. This includes, of course, mesalamine and sulfasalazine. Mesalamine generally felt to be safe and effective. Initial studies had some concern for kernicterus with a compound that was similar to sulfasalazine. That actually wasn't seen in follow-up studies. The only sort of asterisks to this are any products that were previously utilized that were coated with DBP. This has been banned in the United States since 2016, but important to counsel any patients who may be obtaining medications outside of the United States. Sulfasalazine, perhaps a little bit more thoughtful of an approach because it can cross the placenta and may impact folic acid absorption. So if patients are on sulfasalazine and doing well, they may require additional supplementation, or perhaps you could consider transitioning them from sulfasalazine to mesalamine, which has lower levels of fetal transfer. In terms of the immunomodulators, so 6-MP, azathioprine, they do cross the placenta at 5% of maternal levels. The early studies demonstrated some increased risk for anemia in the newborns, but that really wasn't replicated in larger prospective studies. And these drugs really are not associated with poor fetal or infant outcomes. That having been said, we generally will continue patients who are on these therapies, generally in combination with other biologics like a TNF, but we don't start them during pregnancy because of the risk of pancreatitis. What about steroids? So sometimes we just can't avoid them. A patient's flaring, they're in their second trimester. We certainly do need to reach for steroids in certain circumstances, but we try to discontinue them if possible because we know that long-term use is bad for the mom. Increased risk for gestational diabetes, infection, poor wound healing following C-section or episiotomy. Long-term use is also bad for infant and may result in neonatal adrenal insufficiency, premature rupture of membranes, low birth weights, intrauterine growth restriction, and NICU admissions, as well as an increased risk for infant infections up to 4 months postpartum. What about methotrexate? So this is one I really want to spend a little bit of time on. Methotrexate has both teratogenic and embriogenic potential, so we really try to avoid its use in the preconception period, pregnancy, and postpartum. It has been shown to cause congenital abnormalities and to result in spontaneous abortion. So we recommend that patients stop using methotrexate at least 3 months prior to conception and start high-dose folic acid during this period of time as well. You really want to counsel patients to be using durable contraception in the interim. In terms of the anti-TNFs, adalimumab, infliximab, certolizumab, and golimumab, these are IgG1 antibodies that target the TNF alpha. They require active transport via neonatal Fc receptors in order to cross the placenta. Fetal IgG concentrations increase logarithmically from gestational week 20 until delivery. So what that means is that the infant really is not seeing any adalimumab, infliximab, or golimumab until beyond 20 weeks of gestation. Certolizumab, because it lacks an Fc component of IgG1, cannot interact with fetal Fc, which means that it really only undergoes passive placental transportation. And the big take-home point with these medications is that they are safe and effective for patients. We, in the past, had changed dosing strategies to avoid third trimester administration. That is no longer common practice. In terms of the anti-1223s, ustekinumab, risankizumab, mirikizumab, they do cross the placenta in the third trimester, similarly to the TNFs. The offspring will have higher fetal levels than maternal levels at time of delivery. But the data in terms of safety and efficacy is extremely reassuring. No adverse outcomes noted for the offspring nor for the patients. Rates of spontaneous abortion, fetal anomalies are very similar to the anti-TNFs and actually to the general population, which is great. In terms of vedolizumab, similar outcomes and safety profiles compared to the TNFs and the IL-1223s, less placental transfer and more rapid clearance, perhaps. Calcineurin inhibitors like cyclosporin do cross the placenta at 10 to 50% of maternal levels, and the side effect profile really makes this sort of an undesirable choice during pregnancy. Can cause seizures, hypertension, renal impairment in mom, and preterm birth, low birth weight, and spontaneous abortion in infants. Tacrolimus is very rarely used in adult IBD and may require dose titration during pregnancy with an increased rate of preterm delivery and low birth weights. Moving on to the JAK inhibitors like upadacitinib, we don't have robust human data on the safety or efficacy of this medication in pregnancy and breastfeeding. Animal studies utilized 1.6 and 15 times maximum human doses and found dose-related increases in skeletal and CV malformations with increased rates of post-implantation pregnancy loss and decreased fetal body weights. Tofacitinib, a non-selective JAK inhibitor, again, minimal data. Most case reports were that described these drugs used during pregnancy discontinued the use of the drug after the pregnancy was diagnosed. In animal studies, there were teratogenic effects, but those animal studies used way higher doses than we use in human beings. One UC study, the rest come from the rheumatologic literature, are actually quite reassuring, as were 2 case reports that were published in patients who were followed closely with ulcerative colitis during pregnancy and postpartum. We still recommend discontinuing these drugs at least 2 months prior to conception, pending more data. In terms of the S1P receptor modulators, similarly, we just don't have a whole ton of information about the way that these drugs can impact pregnancy and breastfeeding. Most of what we have is extrapolated from the MS literature, and the data, while only including 42 pregnancies, did not show any increased risk of fetal abnormalities or adverse outcomes. The pooled data from MS, UC, and Crohn's disease of 83 pregnancies similarly was very reassuring, but for now we still recommend avoiding this medication during pregnancy and for approximately 3 months after stopping drug. I also want to just make a little pitch here. So it's really important to actually counsel male patients as well. Sulfasalazine can cause reversible sperm dysfunction. Methotrexate can also cause sperm dysfunction and erectile dysfunction as well. And data on paternal biologic and immunomodulator exposure was not associated with an increased risk of adverse birth outcomes. So things that may be concerning to our male patients and may be important for us to be thinking about and counseling them on proactively. We also really want to be thinking about how we can prevent flare-ups. So one thing that we will frequently do is really, really closely monitor biomarkers. C-reactive protein is not reliable during pregnancy, but fecal calprotectin is our most durable biomarker. And as we all know, it can start to rise even before patients become symptomatic. So it's my practice to check the fecal calprotectin prior to conception and in each trimester, and again at the 6 to 12 week postpartum point. You also want to make sure that your pregnant patients are adequately gaining weight, because inadequate maternal weight gain is an independent risk factor for preterm birth, intrauterine growth restriction, and small for gestational age babies. And then you also really want to be focusing on treat to target. So having a low threshold to optimize therapy if patients are on biologics or on an oral therapy. You want to consider weight and circulating volume shifts and clearance shifts during pregnancy as well. If patients do flare during pregnancy, you want to make sure that you are optimizing their medical strategy as quickly as you possibly can. You can think about things like therapeutic drug monitoring, particularly if they're on a TNF, with a very low threshold to increase dosing or shorten the patient's interval if they're on a biologic, or to switch to a different medication if necessary. Again, steroids can be used if necessary, but at the lowest dose for the shortest period of time. And you also want to be sure that you're monitoring patients closely for iron deficiency anemia. IV iron is cheap, it's effective, it's fast, and its use during pregnancy has actually been associated with a reduced risk of IBD in the offspring. Many patients are very concerned about mode of delivery. It's always worth having a conversation. Vaginal deliveries are fine for most of our patients. I do recommend having a low threshold for C-section in very certain circumstances. For example, patients who have active perianal disease, or if a patient with ulcerative colitis, I think, has very high risk for needing a colectomy in the future, and you really want to preserve the integrity of the anal sphincter. You also want to counsel patients about episiotomy risks because, again, the risk of injury to the anal sphincter may be higher in patients undergoing episiotomy. And you also want to think about patients who have had extensive exposure to steroids in the past. You want to think about, femoral head necrosis or risk for hip fracture in those patients. In terms of postpartum, so we really want to keep patients on biologic. Approximately a third of patients will flare in that year following delivery, which is perhaps not surprising. And so you really also want to continue to follow them closely after the delivery point. And in most of our patients, we want to encourage them to breastfeed as well. We found that, patients who have inflammatory bowel disease do breastfeed at lower rates than the general population, perhaps because of concerns about the impact of their drugs on what's going into the breast milk and what will then be transmitted to the baby. But most of the medications that we use in inflammatory bowel disease are perfectly fine to use and safe during breastfeeding, and breastfeeding should be encouraged. The only exception to that is methotrexate, which we do try to avoid. And of course, some of the newer biologics, as I've listed here, are just not well studied as yet. A couple of considerations for the infant. So if biologics were used, a child can receive most vaccines on schedule. MMR and varicella, which are both live vaccines, can be given at 1 year. There's no need to delay rotavirus vaccination for infant. That's data that's come out in the last 24 months. But I do counsel my patients to make sure that they're washing their hands after diaper changes, because infants who have gotten a rota vaccine can shed rotavirus for approximately up to a month after they are vaccinated. You do want to delay BCG vaccination if that's a consideration for your patients until 6 months of age, which will require communication with the patient's child's pediatrician. The only exception is certolizumab. So BCG can be given to babies exposed to certolizumab in utero because of that lack of an FC region. A couple of take-home points here. Early discussions about family planning really can prevent voluntary childlessness and poor outcomes because of education gaps, active disease, and early pregnancy. Biologics are safe and effective in pregnancy, and they should be continued to prevent poor outcomes for mother and baby. You really want to use that preconception period of time to optimize your patients, because that's the key to maintaining remission during pregnancy and postpartum. Proactive monitoring and early interventions for flares protect both mother and baby. Early biologic administration postpartum is a good idea, as well as close monitoring for any changes in their clinical symptoms that may be indicative of flare. Most patients should be encouraged to breastfeed. You should postpone BCG vaccination until the infant is over 6 months, but infants can receive all other vaccines on time, including the rotavirus vaccine.